Hi, good evening, everyone, or wherever you are in the world, as Tim said. Uh, so really welcome. This is a very exciting session for me. We got a topic that really touches many of our patients. It's probably one of the most common surgical conditions there is, and fitting with this, we also have a very exciting panel with representation from really international. We got a nice Brazilian contingent on today, despite the tough loss they suffered on Sunday. So really appreciative of our Brazilian colleagues for joining, but also great diversity, not just geographically, but also in terms of seniority and junior people. Both we got great representations from alumni, from faculty, both junior and senior. So I really am excited about this. And fitting with that theme, we also have an amazing number of registered participants here. We have 1,100 healthcare providers registered from nearly 80 countries. Again, a very nice, strong South American, but also European and Asian representation here. That's some Australia and even Africa. So super excited for this event here tonight. I want to thank our sponsors, Cook Medical, Johnson & Johnson, and Medtronic, as usual, for sponsoring this activity and making this available to everyone to join. So without further ado, we'll take it to introduce our activity directors for this evening with Kristen Ban and Leonardo Dureas to introduce the faculty and the rest of the session.
Thank you, Dr. Liska. We're so thrilled to have put together this wonderful group of panelists and case presenters. Dr. Bama is our in-house robotic guru. She completed her colorectal surgery fellowship at St. Joseph Mercy and University of Michigan, and then additional fellowship training in robotics or minimally invasive surgery and advanced reoperative surgery at Cleveland Clinic. Dr. Shreya Gupta, one of our partners here in Cleveland, who did her fellowship training at Minnesota after her general surgery training at Case Western Reserve here in Cleveland, broad colorectal expertise, and we look forward to their talks.
Thank you. Thank you, everybody, for coming here. We also have Dr. Hall, who is the professor emeritus of surgery from Cleveland Clinic and basically trained most of the panel here. We also have Dr. Luis Lobato from Brazil. He's a clinical fellow in advanced colorectal surgery at Cleveland Clinic, and currently is an adjunct professor of surgery at University of Brasilia. And Dr. Lucas Sobrado was also a former clinical fellow in colorectal surgery at Cleveland Clinic, and he is a colorectal surgeon at Hospitais Clínicas at University of São Paulo, Brazil. And thank you very much for everybody, and thank you for Dr. Liska, our chairman, to organize this.
So I think we're ready to jump into our first talk.
Hi, good evening, everyone. I'm Shreya Gupta, joining from Cleveland, and welcome to CCF Live. I'm going to be presenting the first talk, Observation, Antibiotics, or Resection, and how do we define the threshold for surgery. These are my objectives for my talk. First and foremost, talking about the clinical terminology of diverticulitis. Then I'll go over the evidence, what we have currently for treatment with antibiotics. Then I'll move on to some of the non-invasive interventions and what are the indications. And then finally touch on the role of surgery in the current era. So the burden of diverticulitis, it remains pretty lofty. It has been, like Dr. Liska said, one of the most common surgical conditions we see as surgeons. Diverticulosis is present in nearly 60% of the population by the age of 60. About 4 to 12% of these patients are going to proceed to get diverticulitis in their lifetime. There's a rising incidence in youth colon cancers as well as in youth diverticulitis, and how we are defining this is under 40. There's studies that are ongoing why there is this rising incidence of diverticulitis, but one of the studies that has mentioned a LAMP4 gene, which is present in the myenteric plexus, might have something to do with it, but there's more research to be done in that matter. About 1.9 million cases diagnosed in the ambulatory setting. This was the 2014 survey, and this is already more than a decade old. And a huge healthcare cost burden, aggregates of nearly 1.6 billion over 8 to 9 years. But what we know is that the landscape of diverticulitis treatment is changing. Historically, what used to be the immediate radical surgery, IV antibiotics for long term, this dogma is changing. We're coming towards more less invasive approach for both uncomplicated and complicated diverticulitis. And this shift is really helping us bring down the morbidity, the mortality, and the hospital length of stays, and eventually the healthcare burden, like I mentioned. So most importantly, let's talk about how do we determine these terminology of diverticulitis, because that has changed. The most important thing is that CT scan. The CT scan is the best diagnostic tool that we have for the initial assessment. And as our radiology technology has gotten better, these CT scans are extremely valuable and accessible. This is the Hinchey classification. This has stuck around for decades and it still continues to be very much relevant. Class 1 is your pericolonic phlegmon inflammation. Class 2, interloop or pelvic abscess. Class 3, purulent peritonitis. And Class 4 is your fecal peritonitis. But what has also changed is that we have brought in the uncomplicated and complicated diverticulitis terminology. How do we define that? Well, uncomplicated cases are your majority, 75 to 85%. These are your Hinchey ones, localized inflammation, microperforation. And then your complicated cases are the ones with abscess, fistula, stricture, large bowel obstruction. What has also not, this is still hard to categorize patients because they don't read textbooks. So more studies have said, hey, neither a phlegmon nor just gas tells you that it's complicated. So these findings alone should not tell you that this is a complicated diverticulitis. So just putting a term to these patients is hard. We tried, how about blood tests, right? So role of CRP. Retrospective studies have showed that if a CRP is more than 150, maybe that tells us that this is a complicated disease. But we know it's not that simple. There have been nomograms, prediction models. They have used leukocytosis, abdominal guarding, CRP, and these have come to a negative predictive values of detecting complicated diverticulitis upwards of 96%. This was a study done in 2018, but again, nothing has really taken up in the clinical world and more research is happening in this arena. There are risk factors. So every clinical picture comes with its own set of risk factors. If you have increased BMI, tobacco use, immunocompromised state, all these things are adding up against you when you're trying to term, is it complicated, uncomplicated diverticulitis? So that brings us to the next point. What is the current evidence of treatment with antibiotics? To give antibiotics or not, that is the real question. It brings me to my first trial I'm going to present, the AVOD trial. 2012, this was published in the British Journal of Surgery. It is a Swedish trial. It's at antibiotics for uncomplicated diverticulitis disease. First RCT, and it really challenged antibiotics. It took about 314 patients versus 309 inpatient patients and randomized to either no treatment versus IV or oral antibiotics. The complication rate was 1.9% in no treatment group versus 1% in antibiotic treatment, and the recurrence rates were the same. So this was the first study, RCT, study that really said that, hey, maybe we're over-treating this diverticulitis patients. And an 11-year follow-up, so the longest follow-up that we have, showed that these patients had similar recurrence, complications were the same, the number of patients that got surgery was similar, and so was the quality of life. So this really does drive that point home that, you know, these patients can be just treated with observation. My next trial I'm going to present is the Diablo trial, published in 2017, open label RCT of 528 patients, similar design, inpatient population, put into observe or antibiotics. Median recovery, 14 days in the patients that got observation versus 12 days in patients that got antibiotics. You saw a higher rate of antibiotic-related adverse events, as you can see, and this was statistically significant. And at 2-year follow-up, they saw that, again, similar recurrence rates, similar complicated diverticulitis and readmission. Finally, 2021 Annals of Surgery Dynamo trial, prospective, 480 patients. Biggest difference that this was set in the ambulatory setting and not inpatient, and the design was a non-inferiority. Observation versus antibiotics. Results, they looked at hospitalization rates, and that was 3.3% in the non-antibiotic group and versus 5.8 in the antibiotic group. ED visits, 3% in no antibiotics, 5.8 with antibiotics. So really putting it all together is uncomplicated diverticular disease no longer mandates hospital admission or routine antibiotics, and that observation is the answer, and it's safe and effective. Brings us to our next point. So what are the indications for non-invasive interventions? We know that interventional radiology, our radiographic technology, has really gotten better. So let me back up before I even say that. To all the trainees that are on the live session, this is a very good question. Is all free air bad, right? So if you have a pericolonic air 5 centimeters around the CT scan, is that bad? Maybe, but in a stable patient, it's not. What are the surgical triggers? Extensive air, extensive fluid, maybe telling you that this is Hinchey 3 or 4. And finally, what are the surgical triggers? And it all depends on the clinical picture of the patient. We know that Hinchey 3 or Hinchey 2 and 3 can have abscess. And these abscesses are really see the first line treatment of IR drainage or percutaneous drainage. Complicated diverticulitis, 15 to 40% of these patients are going to have an abscess. And about if the abscesses are more than 3 centimeters, and this might be a little tricky, 3 centimeters is what ASCAR says as the guideline, 3 to 4 centimeters is where the literature is. But around that size and bigger, percutaneous drainage really sees a recurrence risk drop of by 15 to 20%. And usually this is followed up with IV antibiotics. Lastly, let's touch on the role of surgery in the modern era. So emergency surgery in acute diverticulitis still exists. That is the ultimate mainstay for diffuse peritonitis, fecal and peritonitis, Hinchey 4 patients. Patients in whom drainage is not amenable and they fail IV antibiotics also will resort to surgery. The surgical options are sigmoid colectomy, primary anastomosis, Hartmann's. I'll let our next presenter, Dr. Hall, kind of talk. She'll give a whole talk on that, so I'm not going to go into more details. But those are all your surgical options, even in an emergency setting. When we come back to elective sigmoid resection for recurrence or for quality of life impacted diverticular disease, it's really a nuanced discussion. It's individualized. Diseases that have sequelae such as fistula, stricturing disease, these are best treated by surgical intervention. Cases where percutaneous drainage is not amenable, like I said, also most often resorts to surgery. And eventually, it's the number of episodes and impact on the quality of life that brings in the question home, is sigmoid resection the answer for you or not? I like to present my patients with this data because when you're counseling them, really telling them their risk of recurrence, it really does compound. So you have your initial episode, you have an 8% risk followed by 20% if you've had your first recurrence, and then it really jumps to 25% after a second recurrence. And this really tries to help patients make that shared decision making with you. Like I said, ultimately, it's an individualized discussion. But what are the risk factors that you can modify? Tobacco cessation is my number one. Reduced meat intake and really incorporating the high fiber diet. Physical activity and weight loss have really shown in studies to be a risk factor that actually can be modified in recurrence of diverticulitis. I like to touch on this thing which comes up quite repeatedly. So post-episode, a routine colonoscopy is not mandated in uncomplicated cases. So the malignancy myth, if you have uncomplicated diverticular disease and you've had a routine colonoscopy for screening, you do not need that 6 to 8 week follow-up. But if you have complicated disease, abscess, fistulas, then you need to do the targeted scoping, and that's to see the extent of surgery, and that's where the malignancy risks hover about 10 to 15%. One thing I would like to also touch on is what is long diverticulitis. Some of these terms we're going to come across as, again, CT scans are getting so good at it. This acronym SUDD stands for symptomatic uncomplicated diverticular disease. This is prolonged left lower quadrant pain. You can see high fecal calprotectin versus SCAD, which stands for the segmental colitis associated with diverticular disease. This is your endoscopic colitis, smoldering diverticulitis, usually not accompanied by white count or other signs of infection. The treatment for this is not antibiotics, but it's more like IBD, so mesalamine, probiotic, supportive care. Those are your answers. So finally, wrapping it up, we talked about the clinical definitions that are all based on CT scan, and that really helps us to guide what modern treatment algorithm we're going to take. Antibiotic stewardship, that's really paramount. We want to avoid over-treatment of uncomplicated diverticulitis. IV antibiotics and non-invasive measures should be deployed in a stepwise fashion for complicated diverticulitis. And elective surgery is a case-by-case discussion. There's lifestyle and diet modifications. Those all can be the key to altering the course of diverticulosis and recurrences. Thank you.
Thank you so much, Dr. Gupta. And I definitely have some questions for you about antibiotics and thinking about C. diff and also surgery in our younger patient population. But I'm going to let Dr. Dreas introduce our next topic.
So it's a pleasure to introduce Dr. Hall. As I said, like she's basically the mentor of most of us here, like in this panel. And she'll be presenting us with her talk, which is primary anastomosis versus Hartmann, has the debate actually been settled.
So thank you very much for the opportunity to be able to give this talk. Next slide. And these are my disclosures. Next slides. So when you're talking about surgery, you really have three choices. Laparoscopic peritoneal lavage has kind of gone out of favor, but that's one choice. And it still has a place, which we're not going to talk about, but it's something to consider. I'll talk about a little bit at the very end. You have a Hartmann's procedure, which was described in 1931, actually as a treatment for rectal cancer by Dr. Hartmann, that has been adopted now as one of the treatments for diverticulitis, where the bowel is resected and you have a colostomy. And then you have resection with an anastomosis with or without a loop ileostomy. Next slide. And as I said, these are the two choices we're going to talk about. When you do a Hartmann's procedure, it is basically to remove the perforated segment, a colostomy. You either do a mucus fistula of the rectum or oversew it, a drain if you need a drain. The other option is a resection with anastomosis. Next slide. And the reason that this is a surgical topic is because this is still true. 14 to 20% of acute diverticulitis will have emergent surgery. And the problem is that 50% receive a colostomy and 30% at least will become permanent colostomies. So that's why Hartmann's procedure has really fallen out of disfavor and why we're having this discussion. Next slide. So to try to decide about this topic, I looked at the literature, and usually if you look at systemic reviews and meta-analysis, that helps give us at least a start on this. So this looked at anastomosis versus Hartmann's, and they looked at 12 studies. 4 were randomized controlled of 918 patients. The permanent stoma rate, as you would expect, was lower in the anastomosis group. It had the same 30-day mortality in both groups, and their conclusion was you could do an anastomosis in a stable patient that was Hinchy 3 or 4, because that's basically what we're talking about, right? Emergency surgery, Hinchy 3 or 4, and you could expect a lower overall stoma rate and reduced morbidity. Next slide. But the problem with this and many of the studies, it's hard to tease out how many had resection with primary anastomosis and a diverting stoma. And I think when you read all the literature that compares Hartmann's versus anastomosis, the number that had a resection, an anastomosis, and a stoma, next slide, which is depicted in this slide, is really difficult to tease out in a lot of these studies. Next slide. So this was a study that was designed to look at Hartmann's versus primary anastomosis in stable patients with Hinchy 3 and 4. 102 patients, they found no difference in morbidity or mortality. They did talk about 1/3 of the patients with an anastomosis did not have an ileostomy. It's very hard to tease out, though, how they did in comparison to the patients with an anastomosis and no ileostomy. In the long run, 96% of the patients with anastomosis had no stomas versus 65 of the Hartmann's had a stoma that had reversal. So they looked at this as really purporting doing a primary anastomosis with or without a stoma, although you have to really read carefully to find the with or without a stoma. Next. And you can look at a lot of studies that, next. And you can look at a lot of studies and they all have the same type of heading. And it's really hard when you're reading in the very nitty gritty of it to figure out how many patients had a resection with an anastomosis and an ileostomy, because that's kind of the crux of the deal here. Is it's not as you would think at first blush. It's not just most of them, if you can really tease it out, only 1/3 had no stoma at all. Next, please. So this is looking at long-term. This was part of what was called the ladies' trial. And if you've ever heard William Bellman talk, he talked a lot about the ladies' trial. And it was really designed to look at peritoneal lavage. That arm of it, of the randomized part of it, was stopped because the patients did not do well. But they did follow the patients that had Hartmann's versus primary anastomosis. And they came up with, at 3-year follow-up, 66 had Hartmann's and 64 had anastomosis. Again, 30% had no stoma. So there were 2/3 that had anastomosis with a stoma. It's very hard to tease that out, but that's what they found. And they were surprised when they looked at the overall results, because what they found was that there was a 74% closure rate with the colostomy and a 78% with the ileostomy, and they didn't expect it to be that close. And I think that just reflects that if you have a patient with a Hartmann's and you are committed to reverse the stoma, you will reverse the stoma. And why they only reversed 78% of the ileostomies is really unclear. Next slide. So, is this debate actually settled? Next slide. I would say that's a resounding no. Next slide. So what do? Well, I'm going to give you the algorithm that I practice by. Next slide. So if you have to do emergent diverticulitis surgery, you should be thinking about the patient's hemodynamic stability. Are they immune compromised? Do they have really diffuse peritonitis? Are they severely edematous? Are they malnourished? Because all those things will really give you a key of what you should do. If it's a Hinchy 1 and 2, you can do a resection with an anastomosis. And if they have anything that's slightly unfavorable, I would do it with an ileostomy. But most of those patients, you can, if you do an operation and the ends look good and the patients are stable, you can do a resection with anastomosis. I think that the rest of the patients, you would take a laparoscopic or an open look. If they have feculent peritonitis, I still have a hard time really not doing a Hartmann's procedure. So if they're a Hinchy 4, they have to be really in good health with good tissue. And I think in the OR, and when it leads up to the OR, that's really hard to find a patient like that. So what about the Hinchy 3 patients? Well, those patients, if they have any kind of immune compromised, unstable, poor tissues, malnutrition, et cetera, edematous, then I think a Hartmann's is the procedure. Because face it, you want to do what's best for the patient. All this literature is great, but when the patient's in front of you, you've got to think what's the best thing for the patient. A lot of the Hinchy 3s are going to be, as Dr. Gupta was saying, are younger patients. And if you haven't delayed the OR too long and things are relatively in good shape, you can do a resection with an anastomosis. And more than likely, you're going to consider doing a proximal ileostomy, because the reversal of an ileostomy is much easier than the reversal of a colostomy and a Hartmann's. However, that shouldn't guide you. What should guide you is what the patient is like in front of you. And it doesn't mean that you're not a good surgeon if you do a Hartmann's. Next. So my take-home message about diverting is dependent on the surgeon's judgment. There's really no blanket recommendation. You have to treat each patient individually. There's no perfect algorithm for this. You have to think about how severe is the disease, really what's the tissue quality of like, what's the patient like in front of you, their comorbidities. If you do an anastomosis and it doesn't go well, is the patient going to survive that judgment of yours? And what would you want if it was you or your family member? I think that's really, in a lot of the surgical thinking, that's always kept me really able to sleep at night. What would I want for my family or family member? And if the patient's immunocompromised, I think being more conservative is still the right way to go. There's a lot of papers that I didn't touch on because I only had 10 minutes that talk about in immunocompromised patients that you can do an anastomosis. However, those papers also don't emphasize that the majority of those patients have an anastomosis with a proximal ileostomy. So I think if in doubt and you're putting the patient back together, an ileostomy should be what you're thinking about. Thank you very much.
Thank you very much, Dr. Hall. It was like an amazing talk. A lot of questions for sure. That's we're gonna be discussing more about. And Dr. Barron is gonna present our next presenter.
Great. So Dr. Bama is our final presenter. Unfortunately, I believe she is still caught in the operating room. She was gracious enough to pre-record her talk in case this happened. So if we can pull that up, that would be great.
My name is Anurad Obama, and I'm a colorectal surgeon here at the main campus at Cleveland Clinic. And today I'm going to talk about robotics and diverticulitis. This is a pretty broad topic, so today I just want to focus on the operative approach, touch a little bit on the difference in cost with lap versus open, and then also go over several technical pearls when using robotics. Robotics can be applied rather broadly to diverticulitis, from anywhere from simple disease to complex disease, including diverticular fistula and abscess. It's important to remember that the operative approach must match the pathology of the diverticulitis rather than your particular surgical habits. Minimally invasive surgery has certainly grown steadily over the last several decades, and robotic has played a large part in that growth. The adoption of robotics, however, is outpacing the data. And unfortunately, when you look at the data that's available, it tends to be a little bit unrevealing. And we find similar trends amongst studies, especially in the large database studies. Looking back at the decades of research on open versus minimally invasive surgery, especially for colectomies, the data has been very consistent, and this has proven to be true in small studies, large database studies, and randomized controlled trials. As you can see on this slide, there are a lot of improvements that come with minimally invasive surgery that include both immediate postoperative outcomes and long-term outcomes as well. The overall conclusion from all of these studies is that elective resection can typically be done with a minimally invasive approach. We have learned that prolonged operative times do not negate the benefits of minimally invasive surgery, and this applies both to laparoscopy and robotics. However, there are patients where the open approach is going to be the approach of choice, especially in patients who are septic, unstable, or require a damage control operation. These definitely need to have open surgery. But it's really important to know when minimally invasive surgery could be harmful, and it's also important to know when to convert. Now, when we look at robotic surgery, there are certainly a lot of benefits that come along with this approach, and we'll discuss some of these later in the talk. Some of the main things are the 3D visualization and incredibly improved magnification. As you know, the surgeon can control all 4 arms at once on a camera that is stable. There's wristed instrumentation, which allows you to get into very narrow areas. There's also the opportunity for advanced stapling devices, which can allow for intracorporeal anastomoses. And there's also a teaching console as well. When comparing laparoscopic and robotic surgery, there are certainly a lot of benefits and some downsides. The main downside is that robotic surgery takes longer, on average about 40 to 45 minutes, depending on the particular case and where you are in your learning curve. However, one of the things that I find most beneficial with robotics is the ergonomics. As you can see in these 2 photos, there's a significant difference in the way the surgeon is positioned. On the picture on the left, you can see that we're operating very awkwardly. The ergonomics of both of us is not ideal. You can see my resident's shoulders are up, his hands are twisted. I'm not able to use both of my hands because one has to hold up the camera cord because it kept hitting his instrument. However, you can see on the picture on the right, me sitting at the robotic console, operating very comfortably. I wanted to touch a little bit on the conversation about cost of robotics. When looking at the robotic platform, the question is it more expensive? And the answer to that question is pretty complicated. As you can see, there are a lot of factors that influence cost. On the left side, you can see there's operative and patient factors that influence the cost. And on the right side, you can see that there are more financial factors that can influence cost. And so when you look at the overall cost, all in all, it's hard to actually calculate which approach is cheaper. However, there are many studies that show that when you do purchase the robotic platform, the more you use it, the more cost effective it becomes. So to answer the question of is robotics more expensive? Maybe, maybe not. It's important to consider your patient population that you're operating on robotically. There are a lot of studies that show that patients with a lot of comorbidities or elderly or obese can undergo robotic surgery safely. But you need to be comfortable with the technology and understand where you and your entire team are in your learning curve. It's important that both the anesthesia team and the nursing and scrub and assistant team are on board and familiar with the robotic equipment, as you can see on this slide, there are a lot of considerations that need to be thought of when operating robotically, and these typically don't apply to laparoscopic surgery. Preoperatively, I selectively place ureteral stents. There are lighted stents, there's the injection of ICG, and then there are routine straight stents. Typically, you only need it on the left side. However, if you study the patient scan and their history, there may be the need for a right-sided stent as well, especially in patients with complex disease. Being mindful of port placement can really sometimes make or break the operation. I start by looking at the patient's abdomen, assessing where their umbilicus is, what the distance to their xiphoid is, and what the distance to their pubis is. I also look at the angle of their costal margins and assess where I can put how many ports based on the broadness of that angle. I only put in the other ports once the abdomen is insufflated and I know where my target anatomy is. Once you're all set up, there are certain concepts that I'd like to spend a little bit of time talking about. First, don't make the operation harder. Go from known to unknown. Don't start in the area where the colon is inflamed or where there's a fistula. I typically start in a non-inflamed plane where you're not going to have a lot of nuisance bleeding. I tend to do these lateral to medial and take the mobilization up the white line of Tolt and mobilize the left colon off of the retroperitoneal structures. This allows for a lot of length later on. And then I focus on the pelvis where you may run into some bleeding, the fistulas, maybe some small abscesses. When it comes to taking down the fistula, first identify the anatomy. You can utilize EEA sizers or a betadine soak sponge stick if that helps to identify the rectum or the vagina. As far as the instrument selection, I often will switch between the vessel sealer and the scissors. Sometimes the vessel sealer is not sharp enough or has a fine enough point to take down the fistula. Oftentimes I will open the robotic suction because that can also help take down the fistula with suction dissection and can get any of the small abscesses evacuated relatively quickly. There is a special bipolar device for the Da Vinci that is called the Force Bipolar, and this device is very strong, but if you need that strong retraction, this is available. I would say I use this a handful of times throughout the year. Once the fistula is taken down, if there is a visible defect in the other organ, you can close it primarily. Usually these aren't seen, but if you can see it, you can close it. You can also call urology or gynecology to assist with this. Fortunately, these organs tend to be very forgiving and will heal. When there is a fistula, you can consider leaving a drain. I typically don't, but I do leave a Foley and I get a cystogram prior to the Foley removal. Of course, create an anastomosis thoughtfully and divert thoughtfully. With robotics, you can either do a standard extracorporeal anastomosis with laparoscopic assistance, or you can do a total intracorporeal anastomosis with intra-abdominal anvil placement. One of the things that I find most helpful with the robotic approach is anastomotic troubleshooting. Oftentimes, if you have a leak test, as you can see here in this photograph, the dreaded bubbles, I typically redock the robot and then utilizing typically the robotic suction while the assistant is performing a flexible sigmoidoscopy, I'm able to identify where the actual leak is located and suture it closed. In situations where you need to redo the anastomosis, redocking and restapling is pretty quick robotically. And one of the other things that I have found really helpful is when you're having difficulty with even just closing the stapler. If, let's say, the spike and the anvil get unconnected, and then the spike is no longer going through the rectal stump, you can redock the robot and zoom in really close to the rectal stump to see where the spike had come out before, and very carefully with an assistant placing the EEA up to the rectal stump, you can get that spike just through the exact same hole that was there prior. Sometimes when this happens, I will throw a quick purse string around the spike just to ensure that it is tight enough. There are a lot of other operative considerations for diverticulitis. One of the things I like about the robot is that you can really visualize where the tinea coalesce because of the magnification. In patients who have a small bowel fistula because of the diverticular disease, you can easily do a small bowel resection intracorporeally. As I mentioned before, it can help with the takedown of fistulas. I particularly like using the robotic suction in these very difficult cases because just like an open suction dissection can sometimes get the job done. The robotic can certainly help with intraoperative anastomosis, troubleshooting, and intracorporeal anastomoses. If there is a robotic ureteral injury repair, oftentimes the urologists are very comfortable repairing that injury robotically and placing the stent robotically. And also it can help with some mobilization techniques for reach. So for some final thoughts, I think that robotics can be applied broadly, especially in complex cases. There are a lot of things that you can do with the robot that you simply can't do laparoscopically, or that are just much more simple to do robotically and save a lot of time. But at the end of the day, I think your decision to use robotics versus laparoscopy for treatment of diverticulitis is a personal preference. And doing what's best for the patient in your hands is the safest thing.
We're very grateful to Dr. Bama for having pre-recorded that. I know she's also on call, so for all we know, she's doing a diverticulitis case as we speak. We're a little behind. We're going to just tackle a couple of quick questions before we dive into our cases. Dr. Gupta, you alluded to the increasing incidence of diverticulitis in younger and younger patients. Anecdotally, I'm absolutely seeing this. Patients in their 30s, even 20s, who have complicated diverticulitis. How do you factor that into your surgical decision making? And in the patients who do require surgery, what are you counseling them about recurrence in their lifetime?
Mhm. Thank you, Dr. Bam,
For
for that
Dr. Hall
question.
as well, for both of you.
Um, I have seen, I think the youngest I have seen is a 35, so in their 30s, like you mentioned. I really focus on the lifestyle modification. So if they're coming in emergently, I think all the principles that we have talked so far in all the talks goes, right? So age is not a factor. You're still looking at their hemodynamics, their abdominal exam, and then the things that Dr. Holm mentioned, the extent of contamination, health of the tissues, edema, their overall health history. So all those things in an emergency setting kind of go in without the age being a factor. When it comes to the elective sigmoidectomy, I really focus on the lifestyle modification. So is there something that's going to be changing? I don't think high fiber diet prevents recurrence, and that's one of the questions in the chat too. I think it can help if you have diverticulosis. It will help you not get diverticulitis, but once you have diverticulitis, I'm not really sure if studies have shown that it can prevent recurrences. But that's something I still counsel, that high fiber diet. If they have increased BMI, I really do bring in the fact that weight loss is going to be extremely important. And that's where the stoma conversation comes in too. If you have increased BMI, you have increased risks of peristomal hernias and complications from them. And so I really do want to give them the chance of a reconnection and anastomosis in that end. And then finally, tobacco. I have really seen that and this is more anecdotal, is that the younger population that I'm seeing almost always has that tobacco or nicotine abuse with them. So really kind of focusing in that on that counseling is important. And finally, family history. Younger folks probably have not done a colonoscopy, so these are the folks that I really want to hone in on the good family history and then have them do a colonoscopy post episode.
Dr. Hall, any pearls?
So young people having diverticulitis to me is not something new. I mean, I can remember I was just thinking 20 years ago about a 31-year-old young man who had, you know, Hinchy 3 diverticulitis and required an emergency surgery and was very unstable because he couldn't believe he was sick and waited to come to the ER. And that's I know a drastic kind of case, but he was otherwise healthy, ate healthy, was a runner. So I don't think we really know all these things we say. We used to say in the beginning of my career, first episode you have surgery. We've changed that. We're kind of waffling back and forth on that. We used to tell patients, don't eat seeds or nuts. That'll make your diverticula get diverticulitis. We know that is probably not true. There's so much we really don't know, and we console based on I don't know, dogma maybe. So I think that diet is important. A lot of obese people that I've seen with diverticulitis have very, very poor diets, and I think diet has a lot to add in the United States with so many of our health issues. And probably the microbiome, if we really knew a lot about it, has more to add to it. I think just for general health, we need to be counseling our patients more to eat healthy, to, all those things, reduce stress, exercise, all those things. I have seen some studies that show that affects recurrence, but there's so many other things that go into it that, and we're never going to have a randomized trial that's going to show it. It's always going to be some observational type trial. So I think just for general health, those are good things, but whether they really affect recurrence, I'm not sure. I've seen people that have, not taken fiber and had horrible diets and never had another episode of diverticulitis and, barely escaped having an operation the first time. So, I know those are like one-offs, but I think that we need to be thinking of just about general health for our patients, especially in the US.
Right. One quick question for both of you, since you're running a little bit out of time. So we have the case presentations. So, in your opinion, as colorectal surgeons, should we push more for colorectal anastomosis and lumpectomy, or should we go like the regular standard, like Hartmann's? Do you think that, like, as colorectal surgeons, different from general surgery, should we go more for anastomosis and like push the envelope a little bit more?
So what would you want for your family? So that's the first thing. So when you have that patient on the table and you're operating, I think the best rule of thumb is to take a step back and say, if this was one of my beloved family members, what would I want the surgeon to do? Because you have all the knowledge and you have the patient in front of you and you know what's going on. And that has always like I said, allowed me to sleep at night. I think that's the best advice. There are a lot of times I know where people have been criticized in general surgery, ACS, because they do Hartmann's. Maybe that's the best operation they know how to do. If we're not going to take a lot of call as ACS colorectal surgeons, which I know is not the case at the Cleveland Clinic, but it's the case nationwide, then we're going to have Hartmann's to reverse. I think that you have to use your judgment, your surgical judgment. I did probably a lot more resection, anastomosis, and loop ileostomies or no ileostomy than I did Hartmann's in my entire career, because that was what I was taught by Dr. Fazio, and that's what I did. So to me, that I always want to be thinking of a reason why I am not doing that operation. And if I think that the patient is too unstable, there's too much contamination, some other negative factor, then a Hartmann's is okay.
Perfect.
Absolutely. I think the only thing I would add is look at the pelvis, and if the pelvis is amenable to anastomosis, make the anastomosis and do a DLI. But if the pelvis is where you cannot make the anatomy, don't ruin the planes, and do a Hartmann's, and it's easier going back when it's non-inflamed. And if most of the time there are general surgeons who are doing this, and it's pelvis is not the territory they are in day in and day out as we are. And so if they're not, comfortable there, leave it. Doing a Hartmann's is just okay, because then when we go in to reverse that colostomy, we can get urethral stents. You can kind of stage the operation in a way to do it safely. So at the end of the day, I think it's what is the safest and the best thing that you can do in your hands.
Perfect. Yeah, so we're gonna keep going now, like with the case presentation. So we have like two international presenters now. So they will be presenting the diverticulitis cases nobody agrees on. The first presenter is going to be Dr. Lucas Sobrado. He was a former clinical fellow in advanced colorectal surgery at Cleveland Clinic, and he's currently a colorectal surgeon in the Espadas Clínicas in University of São Paulo, Brazil, which is basically one of the main universities in the South America. So welcome, Dr. Sobrado. Thank you for coming. And
Hi, Dr. Durais. Hi, everyone. Thanks for inviting me. It's an honor to be here, to see good friends and good teachers from the Cleveland Clinic. I'm going to be presenting a clinical case of terminal ileitis and colovesical fistula. Is it Crohn's disease? Is it diverticulitis? Or is it both? So let's get started. This is a 60-year-old woman. She had a 6-year history of intermittent mild left lower quadrant abdominal pain, altered bowel habits, and occasional urgency. She had a few episodes of uncomplicated diverticulitis that she was treated as an outpatient with antibiotics. She's a former smoker. She has a BMI of 37. She reports intermittent NSAIDs use due to knee osteoarthritis, and she has a family history. Her mother had severe fistulizing Crohn's disease, required multiple operations, and ultimately died from short bowel syndrome. So at this point, she was being followed at another institution. She had a colonoscopy in 2025 that showed a few scattered aphthous ulcers in the TI. You can see here on the red arrow, some small serrations. Biopsy showed focal active ileitis. She had a CRP of 18 and a fecal calprotectin of 320. And she also had a CT enterography that showed a short segment, less than 5 centimeters, TI wall thickening, and mucosa hyperenhancement with sigmoid diverticulosis. So she was being treated at another institution based on the clinical, endoscopic, and family history. She had a diagnosis of Crohn's disease and was initiated on adalimumab, Humira. So initially, she experienced partial improvement in abdominal pain and bowel symptoms, but then 6 months later, she presents to our emergency department with acute pelvic pain, fever, leukocytosis, and undergoes a CT scan. I'm going to scroll down through to her CT scan here. Once we get to the terminal ileum, you see there's a little bit of bowel thickening here. So here you can see the TI. There's a little bit of thickening, and as we get down the pelvis, you notice the sigmoid is inflamed. There's a little bit of diverticular disease here. And adjacent to the bladder dome, there's a 5-centimeter pelvic abscess, but no evidence of neoperitoneum or free fluid in the abdomen. So she undergoes CT-guided drainage and started on IV antibiotics with clinical improvement. Adalimumab was discontinued at this point because of the intra-abdominal sepsis. She's recommended to undergo elective sigmoidectomy, but she declined. She's very afraid of undergoing surgery, given her family history of several surgeries for Crohn's and short bowel syndrome. So the drains removed after 3 weeks 4 weeks later, she's treated for a presumed UTI by her primary care physician. Another 4 weeks goes by and she develops pneumaturia and fecaluria. She undergoes a new CT scan that confirms a colovesical fistula arising from the inflamed sigmoid colon. So she's admitted, treated for UTI, and undergoes surgery. We do a laparoscopic sigmoidectomy with primary colorectal anastomosis and bladder repair. There's no evidence of small bowel inflammation intra-op, and the Foley catheter is removed on post-op day 10. Final pathology shows chronic active diverticulitis with perforation, multiple diverticula with fistulous tract formation, no granulomas, and no evidence of Crohn's disease. So initially on follow-up, she's doing very well. She's asymptomatic. She's improved her quality of life. Adalimumab was not resumed, and ibuprofen was discontinued. At this time, it was thought that maybe the ulceration, the TI, was due to NSAIDs. But then 6 months after surgery, she develops mild right lower quadrant abdominal pain and increased bowel frequency. Her current status is a CRP of 17 and a fecal calprotectin of 720. She's currently awaiting a repeat ileocolonoscopy to evaluate for possible Crohn's disease. So the case is not over. We're not sure how what this will show, but I think there are some takeaways and discussion from this case. So is it Crohn's, is it complicated diverticulitis, or is it both? I think first of all, Crohn's disease and diverticulitis can coexist. Non-specific terminal ileitis is not always due to Crohn's. It could be to NSAIDs or infectious disease. On this particular patient, operative findings and pathology favored complicated diverticulitis, but she also has a strong family history, recurrent symptoms, and post-op elevated fecal calprotectin that raise concern for Crohn's disease. And a few questions. Should a needle cecal resection have also been performed at the index operation since she has short segment disease? Should Humira have been started on a patient with terminal ileal inflammation and a history of recurrent diverticulitis? Should we resume biologics? I think her next colonoscopy will have guiding for the treatment for this patient.
Dr. Hall, Dr. Gupta, trying to address those questions. And another question too for Dr. Gupta, like, is this the case that you are talking about, the long diverticulitis?
Yeah, I brought that up because as these patients are seeing more and more CT scans, I feel like we're seeing a lot of scads and SUDS on the CT scan, and patients are coming back to us so with prolonged symptoms and not knowing they don't have white count, but they have left lower quadrant pain. And so IBD in the picture of recurrent diverticulitis is becoming more and more common and harder to parse out. Dr. Sabrata, couple questions. Did you ever get a CTE again after your sigmoidectomy?
No, not yet. No, she had a CTE last year. Yeah, before surgery.
Yeah. And did you have inflammatory markers post your sigmoidectomy, the CRPs and fecal calpro?
Yeah, so 6 months after surgery, she has an elevated CRP, 17, and a fecal calprotectin of 720. So yeah, it's elevated. We weren't expecting it to be so high.
Yeah, I think it's definitely a possibility you have both processes going on. Definitely what you did with the sigmoid was from recurrent diverticulitis in the fistula as a consequence. The terminal ileum is definitely, if a CTE will show you if you're dealing with something fibrostenotic versus active disease. And that's why I mentioned even with the CTE, your colonoscopy is definitely going to be helpful too, but that CTE or MRE is really going to parse out if this is fibrostenotic, and that's what's going to guide me to whether or not you want to reintroduce the biologics before you go performing more surgery. To answer your question on the slide, would have I done both at the same time? I would say no. I think you had a very clear-cut indication of taking down the colovesicular fistula, which was getting the patient sick at the time, and so that's what I would have addressed. But clearly 6 months later, her Crohn's or IBD is still acting up, and that needs more workup and possibly medical therapy prior to surgery.
Yeah, I
Dr. Hall?
agree. Yeah.
Dr. Hall, any comments?
So I think this is Crohn's with diverticulitis. I think, you know, it's rare to have two issues, but I think this is clearly two issues. Would I have done the ileo resection at the time of the diverticular resection? I would have looked very carefully at it. I think you said it looked normal, but I would have really looked that over and made sure it was normal, because this would be exactly what I would be afraid of. You're back at 6 months and you have disease. I would have had a very low threshold once I was happy that her anastomosis was fine to restart the biologic, because you haven't cured her Crohn's disease. I think, I mean, I see GI people do this a lot, where, you know, you have surgery for something else like a gallbladder out and they stop the biologic. Well, we haven't done anything about helping the Crohn's disease. If you would have taken out her ileocecal region, then I probably would have not restarted the biologic. But you have to think about the whole patient and what's going on. And I would have had a very low threshold to restart the biologic probably at about 4 weeks after I was sure the Foley was out, et cetera, et cetera. Now you need to work her up like somebody with Crohn's disease. You need to get a CTE, you need to do a colonoscopy, you need to look at the TI. And then you have to decide if you're going to treat her with something more advanced than adalimumab.
Yeah. And Dr. Hall, would you be concerned about giving a patient biologics if they have a history of recurrent diverticulitis because of developing pelvic infection? Like, she started on Humira and 6 months later she develops a pelvic abscess. Was that coincidence, or do you think that might have played a role?
Dr. Hall, you're muted.
That's a great question. I don't know if you'll ever be able to answer it, because there's people on both sides of the fence. People that say, oh yeah, that led to the diverticulitis and the aggressiveness and the abscess. She's a portly lady. She's got a lot of adipose tissue. So I'm not so sure that she doesn't have a lot of the risk factors that were talked about in the first talk. So that one I don't, you know, I don't ascribe to that. So I'm not so sure that's the be all and the end all. I think now the thing you have to think about is, okay, I think she has Crohn's disease, and you have to work her up for a Crohn's disease and then decide if you're going to use a more advanced therapy.
Perfect. Thank you so much, Dr. Sobrado. It was a great presentation. Let's move on with Dr. Lobato. So he was also like a previous a clinical fellow at Cleveland Clinic, and he is currently an adjunct professor of surgery at University of Brasilia School of Medicine, which is in the Brazil capital. And thank you so much, Liz, for joining us. Your turn.
Thank you very much, Leo. Thank you very much, Dr. Liska, Dr. Ho. It's a great pleasure for me to be here, and a great honor to our university. So next, please. As I said, I have no disclosures. And the next. Okay, so this is a patient that I saw at my clinic. She's a 47-year-old female. She came with a history of diverticulitis. She did a colonoscopy and a CT scan that showed that. And she had a history of 6 previous episodes of diverticulitis, all of them non-complicated, but 6 episodes. And every single one was documented with being located at the sigmoid colon. And based on that, we decided to do elective surgery. So next, please. So this is what we found. We decided to do a robotic sigmoid resection. And during the surgery, it was very, very hard. Because of the recurrent sigmoid diverticulitis, we had all those chronic inflammatory changes. And the mesentery was very thick and very short. Actually, I like to think that every time that I'm going to operate on a patient with diverticulitis, if the surgery is very easy, it means that I shouldn't be operating on that patient. We should anticipate that these patients will have a very hard dissection. And because of the mesentery alteration, it was very hard to find the correct plane. I found myself getting to the mesentery a couple times. And we had a prolonged operative time, but we were able to do the operation. So next one. So I would like to invite you guys to think about this. At the end of a difficult minimally invasive sigmoid resection, what do you do with the mesenteric defect? Do you leave it open, what we commonly do in minimally invasive colectomies? Do you close selectively when anatomically concerning, close routinely, not sure? I can tell you what I did. I left it open. So move on. Next, please. Patient went home on postoperative day 5, but on postoperative day 7, she came back with small bowel obstruction. She had abdominal distension, history of no passage of stools, flatulence, and she was vomiting. Physical examination, she was dehydrated, heart rate 110, blood pressure 100/70. The workup showed repeated the labs. She had 13, the white count was 13.5, hemoglobin 13, and I ordered a CT scan of the abdomen and pelvis with IV contrast, placed the NG tube that came back 1,000 cc's of feculent output, and we started on IV fluids for her. And what happened is that when I ordered the CT scan, I was expecting to see small bowel obstructions due to adhesion. And as I learned it from Dr. Faz and Dr. Ho, usually those patients can be just observed and managed without an operation. But next one, please. So this is the CAT scan. And the CAT scan came showing to us a highly concerning for internal hernia through a postoperative mesenteric defect. The patient was not doing well, she had more pain, and we decided to operate on her. Next one. And this is what we found. Actually, you can see on the left side of her screen, it's a representation of what we found. The small bowel went underneath the descending column and came back immediately through a window that I opened in the mesentery. I was able to reduce it. There was no need for a small bowel resection, and then I just closed the defect. Patient went back home on postoperative day 4. Next one. So what I think that this case, it's important for us. Every time that we need to operate on a patient with 6 episodes of diverticulitis, we should anticipate that the mesentery will be thick, short, and the planes will not be clear. If the resection is very hard, we should always look for mesenteric windows. I think that when I was trying to get into the plan, I probably made a window, and that was the place where the small bowel came back and herniated. And there is another point. We're talking about robotic surgery. It's way much easier to close the defect when you're doing it robotically comparing to laparoscopic surgery. So perhaps we should consider it routinely closing those mesenteric defects when you're doing the surgery through the robotic platform. Thank you very much.
Thank you very much for a great case. So, Dr. Hall, do you usually close? Dr. Gupta, do you close like defects, and what to do in case of a hernia after?
So I commend them for operating, because a lot of times surgeons will, especially post-operative day 7, sit on something like that, and then you end up having ischemic small bowel. When you're doing, let's just go back to the basics of the operation. I know this was a very difficult dissection, but when you're doing it, a lot of times when you're operating, you're taking the IMA, you're taking the splenic flexure down, you're creating a window underneath the left colon that the small bowel can sneak through. This is a little different. This was a window in the perpendicular part of the mesentery, which it sounds like you probably made when you were trying to get into the right plane to do the surgery. I routinely don't close all of those, but something like this, it's a little different. This is a different kind of a defect. You know, I think that you have to do it on a case-by-case basis. But if you have a big defect, it's, you know, always safer to close it, I think. Carefully close it. Don't nail a blood vessel. But I think that this is pretty rare instance. I mean, the small bowel is pretty sneaky. We know that, but this is a pretty rare instance.
Since we had this case, like I want to see, Dr. Gupta, what do you think about robotic surgery for diverticulitis and diverticulosis?
It did one today. I think that it's extremely useful tool, especially getting down into hostile pelvis and getting your angles, getting that articulation. There's also a time and place where robotics is not the answer, which is emergency surgery, in my opinion, just because of the availability in the planes. But when you are dealing with this complicated diverticulitis and doing elective operations, I think it's a fantastic tool when used appropriately. Dr. Lobato, that's a challenging case and not something that I have seen. I'm sure that the mesenteric defects were, if you're saying that you had the defects, I'm assuming that it was so inflamed that even trying to routinely close them at the end of the case may have gotten into a lot of, like, you know, bleeding and maybe the suture kind of, not coming through. So I'm not really sure if, like, in the case that you're describing, if you would have, doing a routine closure would have, been the right answer either. I think I do give kudos, just like Dr. Hull said, like not sitting on it on day 7 and doing a very prompt exploration was the right thing to do. Not sure if that's something routinely that needs to be done. I think it's just a rare instance that it can happen.
Yeah, I agree with you, but every time that I have a problem, I keep thinking what I should have done differently to avoid that problem. So, and making the suture with the robotic is so much easier than doing this laparoscopically. And if we were doing it open, we would be closing it. So I'm always thinking robotic surgery is another tool in your toolbox. So you shouldn't be doing surgery in a different fashion just because you're doing it robotically. I think that if you are able to close, perhaps this is something that we should do. The next case I will have, I will look for it because I didn't even look. I didn't even consider to close the defect. I mean, I just left it there. So the next one, maybe if it's feasible, I would be tempted to do that.
I know we're out of time. There's a question in the chat about during laparoscopic surgery, do we routinely close the mesenteric space? And I just want to provide clarification because this case was a window within the mesentery. And just very quick for our case presenters, for our faculty on today, do you routinely close the mesentery to whether the retroperitoneum or other tissue, just for clarification in the chat?
I don't selectively. I will close when I mobilize the splenic flexure. If the colon comes down to the pelvis too floppy and there's a big window, sometimes I will close. But if it comes down flush with the retroperitoneum, then I think it's very unlikely that the patient will have an internal hernia. And there's also a risk of injuring the marginal arcade. So often I won't close, even if it's open or laparoscopic or robotically. To me, it doesn't really matter.
And for me, I don't close as long as it's big. I do look for it, especially when I'm doing the rights. I make sure that I'm looking for like very wide mesenteric defects and I leave them open.
I wouldn't have routinely closed. And I just wanted to add something that he is bringing up. Dr. Fazio used to say your technique changes based on your last complication. This is a good example of it.
Well, thank you to our faculty, to our case presenters. This was a really dynamic topic. We could have spent a lot more time. I don't know if Dr. Liska's on. If he is, do you have any final words?
No, I agree. It was really excellent session. Thank you, Dr. Ben, Dr. Durez, for putting it together. Thank you to all the faculty. Great cases from Brazil. Really appreciate alumni coming together for this excellent session this evening. So thank you all, and thank you everyone in the chat for participating and for your questions. And really nice participation. And there's a lot of people who also view this presentation asynchronously. So really appreciate everyone participating. Thank you.